Hello and welcome. Today we're diving deep into a true master of persistence, the hepatitis B virus. You see, even after a patient appears to be completely cured, this virus has a remarkable ability to lie dormant, sometimes for decades, creating a hidden but very real threat of reactivation. And managing this threat, well, that requires constant vigilance and a really deep understanding of how this virus operates. So here's our game plan. We're going to start by really understanding the pathogen itself. Then, we'll get into how we diagnose it and assess the risk of it waking up. After that, we'll cover the specific strategies for prophylaxis and treatment, zoom out to look at public health, and finally, bring it all together by looking at the serious complications and some real-world clinical cases. All right, first things first. If we want to manage hepatitis B, we absolutely have to understand the virus itself and its pretty unique lifelong behavior in the human body.
So what exactly is hepatitis B? It's a small DNA virus, and it's unique to us humans. But here's the absolute crux of our entire conversation today. It's persistence. Even when a patient seems to have recovered, and even when their surface antigen clears, the viral DNA can remain tucked away inside liver cells, the hepatocytes, potentially for a lifetime. This latency is the very source of the reactivation threat.
This timeline really shows the typical journey of an infection. You have the incubation, the acute phase, and then a patient might go into a chronic phase, or they might even appear to clear the virus. But the key phase to focus on is post-clearance. That's almost a misleading term. This isn't eradication, it's latency. That persistent DNA just sitting there means reactivation is always a possibility. Okay, so if the virus is a master of hiding, how do we find it? And maybe more importantly, how do we figure out who is most at risk? This brings us to the really crucial steps of diagnosis and risk assessment. Diagnosing HBV is all about interpreting a panel of serological markers. It's like detective work. The antigens, like HBsAg, tell us there's a current infection. The antibodies tell a story of past exposure and immunity. But the real smoking gun, the definitive proof of active viral replication, is a quantitative HBV DNA test. That's what gives us the viral load. Now, HBV reactivation isn't just a vague concept. It has a very precise clinical definition. It's one of three things. Either viral DNA suddenly becomes detectable when it was gone, or the viral load spikes by a factor of 10 or more, or, and this is the most dramatic sign, you get what's called reverse seroconversion, where a patient who is negative for the surface antigen actually becomes positive again. This table really shows why we have to be so vigilant. Certain powerful immunosuppressive drugs can wake this sleeping giant. Take rituximab, for instance. It depletes B cells, which effectively cripples the body's ability to keep HBV in check. And notice, the risk is extremely high for an HBsAg positive patient, sure, but it's still high even for someone who just has evidence of a past infection. This makes screening before therapy completely non-negotiable. So, we've identified the threat, and we know the scenarios that can trigger it. Let's talk about the solution. How do we proactively neutralize this threat with the right prophylaxis and treatment? For these high-risk patients, the protocol is a very clear three-step battle plan. First, you start antiviral prophylaxis 2 weeks before the immunosuppression even begins. Second, you keep it going for at least 6 months after the therapy ends. And third, you maintain that vigilant monitoring. This proactive approach is absolutely key to preventing a dangerous reactivation. Now, what about an acute exposure, like a needle stick in a healthcare setting? The response really hinges on the person's vaccine history. If they're a known responder, we can just boost their existing immunity with another vaccine dose. But if they're a non-responder, we can't afford to wait. We have to provide immediate passive immunity with hepatitis B immunoglobulin, or HBIG. This level of clinical nuance, it always reminds me of something a professor said in medical school. He said, if you want to understand infectious diseases, you must think like a pathogen. Always find the path of least resistance, but never neglect the unexpected host. In HBV strategy, persisting, waiting for that path of least resistance, it's a perfect example. That same mindset helps us shift from individual care to public health. So let's zoom out and look at the public health scale.
Containing a virus as persistent as HBV isn't just about treating one person at a time. It requires really robust systems at the population level.
One of the most powerful tools we have is actually data. Hepatitis B is a mandatory notifiable disease. That means labs and doctors have to report a confirmed case within a single day. This isn't just bureaucracy. That speed is absolutely critical to kickstart source and contact tracing, which allows public health officials to break those chains of transmission and protect others who might have been exposed.
Nowhere is infection control more rigorous than in healthcare settings. It's a defense in depth, mandatory vaccination for at-risk staff, followed by monitoring of their immune response, and very strict protocols for those who don't respond. That specific viral load cutoff for infected workers, 1,000 IU per ml, just shows you the precision involved in protecting both the providers and their patients. So why all this complexity? Why the intense protocols? Because the consequences of an unchecked infection are just so severe. Let's quickly go over the major complications before we test our knowledge with a few clinical scenarios. If it's left unmanaged, chronic HBV can lead to truly devastating outcomes. We're talking about liver cirrhosis, hepatocellular carcinoma, and acute liver failure, which, as it says here, is often fatal when it happens after a reactivation event. This ties everything we've discussed directly back to the central threat. On top of that, co-infections with other viruses like HDV or HIV can pour gasoline on the fire, making the disease progress even faster. All right, time for our first clinical challenge. We have a 45-year-old male. He's HBsAg positive, and he's about to start rituximab for lymphoma. We know that carries an extremely high risk. So what's the plan? The correct answer is to act proactively. You start the antiviral prophylaxis 2 weeks before the rituximab, and you continue it for a minimum of 6 months after the therapy is finished. That is the protocol in action, plain and simple.
Second challenge. A healthcare worker who we know is a vaccine non-responder gets a high-risk needle stick from an HBsAg positive source. What is the correct post-exposure prophylaxis, the PET?
Right. You can't rely on a vaccine here. The protocol is clear. You provide passive immunity with 2 doses of hepatitis B immunoglobulin, 1 month apart, to neutralize that virus immediately.
And our final case. A baby is born to a mother who is a chronic HBsAg carrier. What's the immediate plan to prevent that vertical transmission from mother to child?
Here, time is absolutely everything. The infant needs that passive protection from HBIg within just 2 hours of birth, and then you follow that up with the first HBV vaccine dose within 48 hours to start building its own active immunity.
And all of this brings us to a final, pretty profound question. Given this virus's incredible ability to integrate and persist within our own cells, is hepatitis B ever truly cured, or is it simply a condition to be controlled? You know, the answer to that question, whatever you believe it is, really defines our lifelong duty of clinical vigilance. Thank you for joining this explainer.